Hello, my name is Sibel Aydın. I'm an associate professor in medicine in University of Ottawa, Ottawa, Canada. In this video, we're going to be talking about the entheses around the knee, the quadriceps tendon, the origin and insertion of the patellar tendon, and the origin of the medial collateral ligament. So let's start with the quadriceps tendon first. The quadriceps tendon is formed by the four individual tendons of the quadriceps femoris, which are rectus femoris, vastus medialis, lateralis, and intermedius. They can be separated from each other until 1 cm above the insertion. These layers fuse with each other after this point and become inseparable. The quadriceps tendon inserts into the superior pole of the patella with a large footprint. Some of the superficial fibers of the tendon cross over the patella and is a continuum with the patellar tendon. For the ultrasound assessment, the patient lies in supine position. When relaxed, the quadriceps tendon has a concave course, and this may cause anisotropy during the ultrasound scan. This can be avoided by putting a pillow beneath the knees to provide 30 degrees of semiflexion. In this view, the ultrasound beams would be perpendicular to the tendon. The ultrasound examination in B mode is done to look for signs of enthesitis, such as hypoechogenicity, thickening, enthesophyte calcifications, and erosions. There are a couple of key points when assessing the quadriceps tendon enthesitis in B mode. One is to make sure that the whole length of the quadriceps tendon is included in the scan. The enthesophytes are usually located at the distal end of the insertion, therefore not including this part in the view may result with missing the enthesophytes. For example, this image shows truncation of the distal part of the enthesis, and moving of the probe distally allows us to show the entire enthesis. The width of the quadriceps tendon also needs to be considered. Because it's a wide enthesis, the sonographer needs to sweep from medial to lateral ends of the enthesis to ensure that the whole enthesis is scanned. Particular attention needs to be paid to avoid anisotropy. Despite the semiflexion of the knee and the correction of the concavity of the tendon, there will still be an angulation between the quadriceps tendon and the probe. The probe may need to be tilted to make sure that the examination is not going to be limited with anisotropy. All pathologies need to be confirmed in transverse view also, and this should include the scanning of the enthesis proximal to distal by sweeping the area. For the Doppler assessment, the stretched tendon fibers may compress the vessels. To be able to detect the vascularity with a higher sensitivity, the knee needs to be brought in full extension. It is important to focus on the location of the Doppler signals to ensure that the signals that are outside the quadriceps tendon borders are not misinterpreted as Doppler positivity. And now we're going to move to the patellar ligament. The patellar ligament lies in between the inferior pole of the patella and tibial tuberosity. The origin of the patellar ligament expands to the medial and lateral edges of the patella and continues with fibrous patellar retinacula on both sides. The ultrasound scan starts by placing the probe on the inferior pole of patella to visualize the origin of the patellar ligament. The whole ligament can be visualized until it inserts to the tibial tuberosity. Similar to the quadriceps tendon, with the knee being fully extended, the patellar ligament has a slight concave appearance, which may cause anisotropy. Approximately 30 degrees of flexion of the knee would provide a straight appearance of the ligament. This allows the appreciation of the borders as well as the fibrillar ecotexture by minimizing the anisotropy. The assessment of the patellar ligament by ultrasound requires a thorough scan of the ligament from medial to lateral to ensure coverage of the total width. Proximally, the ligament is thin and wide, while with the fibers converging distally, it becomes thicker and narrower at the insertion to the tibial tuberosity. Therefore, a mild increase of the thickness at the tibial insertion, especially in the absence of any hypoechogenicity and fibrillar ecotexture, should not be misinterpreted as abnormal thickening. The insertion to tibia can be identified with the prominence of the tibial tuberosity. The full length of the enthesis needs to be scanned for features of enthesitis, especially at the distal end of the insertion, not to miss the enthesophytes. The angle of the fibers at the origin and the insertion of the patellar ligament may cause anisotropy on both sides, so the scanner needs to be careful not to overcall the hypoechogenic appearance that is due to anisotropy. Tilting the probe and being perpendicular to the fibers helps to avoid anisotropy. This can be done by heel-toeing the probe. Deep to the patellar ligament, Hoffa's pipette fills the space in between the patella and the tibia. The deep infrapatellar bursa is a synovial tissue that lies between the distal patellar ligament and the anterior aspect of the tibial epiphysis. Healthy people may have mild effusions in this bursa, which should not be considered as a pathological finding. All findings in longitudinal views needs to be confirmed in transverse view. This is also useful to make sure that the whole length of the patellar ligament is scanned, especially at the proximal origin. Moving to the Doppler assessment, similar to the quadriceps tendon, to increase the sensitivity and avoid compression of the small vessels between the fibers, the Doppler should be assessed by bringing the knee in full extension. It is important to accurately define the location of the Doppler signals and not overcall the feeding vessels as pathological. The feeding vessels may be close to the insertion, but the transverse view would help to determine whether the signals are within the borders of the ligament or outside. Next, we're going to move to the medial collateral ligament. The medial collateral ligament lies in between the medial femoral epicondyle, starting around 5 cm above the joint, and inserts into the medial aspect of the tibia after running a long course. It has a superficial and a deep layer. The deep layer is attached to the joint capsule and lies over the medial meniscus and is formed with the meniscal-femoral and meniscotibial ligaments. To be able to visualize that ligament, we need to change the position of the patient. Now we need to externally rotate the leg, keeping the knee semi-flexed at about 30 degrees. The transducer needs to be placed in an oblique position to be able to cover the long axis of the medial collateral ligament. The examination should start at the level of the medial joint line. At this level, medial collateral ligament can be seen as the fibrillar ecotexture, and superficial and deep portions can be separated from each other. Then the probe would be swept proximally to the medial femoral epicondyle without losing the fibers of the medial collateral ligament from the view. The enthesis would include the insertion of the superficial and deep portions of the medial collateral ligament, the superficial portion being more proximal and the deeper portion being more distal. Between these two layers, there may be a bursa which is easily compressible and hard to see. At this level, we would look for signs of inflammation and damage. The absence of fibrillar ecotexture and hypoechogenicity, as well as thickening at the level of the insertion, would be investigated. Similar to the other enthesis, the bone profile would be screened for erosions and enthesophytes. Every pathology needs to be confirmed in transverse view. The Doppler settings should be arranged in order to visualize the vascularization of the superficial tissue.